I'd just like to thank Ruth for reaching out to me and sort of inviting me. It's an absolute delight for me to sort of talk about shoulders at any time, but especially to this group who are a very important part of my practice. And obviously I've known Ruth for some time now, and I'm delighted to be here tonight. Hopefully over the next, sort of 45 minutes, I can sort of take you through a little bit of a whistle-stop tour of shoulder pain, and also make that a bit more sort of obviously relative to, Parkinson's disease. For those of you who don't know me as well as Ruth, I graduated from the rugby club called St Mary's Hospital in London, where you basically play rugby and learn some medicine on the side. I was then fortunate enough to go through my orthopaedic training in London. And then I was awarded the British Orthopaedic Association European Travelling Fellowship, where I was fortunate enough to learn from 4 of the world's leading shoulder surgeons in Italy, France, and Switzerland. And following that, I took up a consultant post a decade ago now at West-Herts, and I now sort of practice at Spire, Harpenden, Bushey, and OSD Healthcare in Hemel Hempstead. And shoulder pain's really my passion. I'm dedicated to shoulder and elbow surgery, and it keeps me pretty busy, because if we look at shoulder pain in the general population, there's a prevalence of about 1 to 2% of adults will go and see their GP annually regarding a new episode of shoulder pain, and it accounts for about 2.4% of all GP consultations, which is really quite huge when you think of all the things that could go wrong in the body, which causes you to go and seek a GP appointment. It accounts for 2.4%. And the causes of shoulder pain, we can roughly divide them into things that affect the tendons. So the group of tendons in the shoulder we call the rotator cuff. That's the family name for the tendons in the shoulder. And they can go through impingement, where they're sort of rubbing and giving you pain, or they could even develop tears, which become more frequent as we get more mature. Frozen shoulder is a big problem, and we're going to talk quite a bit about that soon. Arthritis, and obviously you can get sort of general injuries. But if we focus on Parkinson's, quite often, and I see this a few times a year, shoulder pain can actually be sort of the first sign of someone developing Parkinson's disease. And if we look at it another way, in the Journal of Clinical Rheumatology a few years back, it was noted that shoulder pain affects about 11% of patients with Parkinson's disease, which I thought is actually, it's quite a huge proportion. Over 1 in 10 of people with Parkinson's will get shoulder pain at some point. And quite often they present to our clinics with a stiff shoulder. And it's therefore often a misdiagnosis of a frozen shoulder, when actually it's the Parkinson's which is presenting. And indeed, Riley, back in good old 1989, did a survey of 150 patients with Parkinson's. And it was actually found that 12% of those patients had symptoms which were seen at the time to be consistent with a frozen shoulder up to 2 years prior to the onset of more common symptoms of Parkinson's disease. And because I'm sort of dedicated to shoulders, I do see these issues a bit more frequently. And I do look out very much so when someone presents with a frozen shoulder, or what I think is a frozen shoulder, is to look for other signs or potential symptoms of Parkinson's to see, is this someone who I actually need to get my neurology colleagues to see? But in general, for the general population, pain and stiffness is usually caused by either frozen shoulder or shoulder arthritis. So let's just dive into a little bit about each of those conditions. A frozen shoulder was first described historically by Ernst Amory Codman back in the 30s. Codman was essentially one of the forefathers of shoulder surgery. And it was in 1934 that he described a frozen shoulder as a slow onset pain that you experience around the deltoid muscle, which is at the side of your shoulder, and that often it would keep people awake, and that they would then notice a restricted range of movement. But what was important is that he also described a normal radiological appearance. And what he was getting at is that you've got a normal x-ray i.e. you've not got arthritis as the cause of the pain and stiffness. So whenever someone's diagnosed with a frozen shoulder, we normally do some form of imaging, such as an X-ray, to make sure that they've not got arthritis. And frozen shoulder in the general population is actually quite common. 8.2% of men and 10.1% of women over working age suffer a frozen shoulder. If you do get a frozen shoulder, can you get it in the other side? Well, actually, 6 to 17% of patients get symptoms again in the other shoulder within the next 5 years. And what's interesting to note is that if you're diabetic, you've got 2 to 4 times the general the risk compared to the general population of developing a frozen shoulder. What causes a frozen shoulder? At present, we don't actually know. We know what the cells look like, we know what the tissue looks like, but we don't know what the stimulus is. And most frozen shoulders are what we call primary idiopathic. And what that means is that essentially we don't know. It just comes on out of the blue. It can be associated with diabetes, or if people have had a fall or suffered a major injury, or even had a stroke or a heart attack. But generally speaking, the vast majority of cases of a frozen shoulder just comes on out of the blue. But what I would say is that people who are diabetic or have had a frozen shoulder after a fall usually get a worse type of frozen shoulder. It's usually more painful, more stiff, more resistant to treatment. And generally you get a pain before the stiffness comes, but then gradually the shoulder becomes very stiff, it becomes very tight. There's lots of cells in the tissue that make the tissue sort of contract, and that then limits your range of movement. And classically, you go through 3 phases. Initially, there's a freezing phase where basically you have a lot of pain, and the pain is certainly more than the stiffness. And any loss of range of movements is generally because of pain inhibition. The patients don't want to move their shoulder because it's just so painful. Now, that can last for a number of months before patients then enter the frozen phase. Now, in the frozen phase, it's the stiffness which becomes more apparent rather than the pain. And then the patients often have very limited movement, which is really affecting their daily life or their occupation. Now, if you leave a frozen shoulder long enough, it'll gradually thaw. And then ultimately, most people will get their range of movement back. However, what usually makes patients' hearts sink is when you tell them that on average, it takes 2.5 years for someone's frozen shoulder to thaw. And that's a long time to be in pain and have stiffness. So in the good old days, Ernst Amory Codman and the original text would say, humour the patient through the course of their disease, for eventually it will get better. However, in today's modern age, telling someone that you're just going to leave them alone for 2.5 years doesn't usually cut the mustard. So what do we do with patients? Well, first of all, what would happen if we did nothing? Well, most people do get better, but research has shown that at 7 years following a frozen shoulder, about half of people still have some mild pain or stiffness. Okay. However, in general, people have felt that their functional restriction was quite small. Treatment depends on what stage of the process you're in. If you're in that initial freezing phase, the most important thing is to try and control the pain. Use painkillers, use steroid injections. It's not sensible to start trying to do aggressive stretching exercises, because you're just going to get a whole load of pain, and then you won't want to do the exercises at all. Exercises and physiotherapy come in when it's later on, when the stiffness starts to set in, when you can try and stretch the capsule, when the pain's not as bad as it was initially. Now, if patients are really struggling, what else can we do apart from physiotherapy and injections? Well, we can manipulate the shoulder. We can try and distend the shoulder, try and stretch it out. And we can also do a keyhole procedure where we actually clear the tissue out and release the painful tissue. Now, manipulation, yes, it's quick, it's easy to do. However, you still need a general anaesthetic for it. It's not something that you can do in outpatients. You still get admitted to theatre. And there's a very small risk of either chipping the bone or getting a nerve injury. If we do a dilation where we inject saline into the shoulder to try and distend it, that can work well. However, some patients find it pretty uncomfortable. If we do an arthroscopic release, one of the advantages is that we can actually see what we're actually releasing. We can inspect the joint because we've got a camera inside. And you'll see on that photograph, lots of pink red tissue. That's not normally there. That's quite florid inflammation, which we classically see in someone who's got a frozen shoulder. And now I'll show you a little video clip of how we release the frozen shoulder. So we've got a camera in the back looking towards the front of someone's shoulder. There's tendons up the top right, the top left. And this painful red inflamed tissue is now being cleaned out with me using what we call a radio frequency probe. So think of it as a fancy electric cautery stroke hoover, okay? So I can then carefully make sure that we don't damage any of the normal tissues, but I can go through and release all this stiff, painful tissue at the front of the shoulder. And by the time I've released this tissue, patients will then be able to rotate their arm outwards, which is one of the major restrictions. Patients with a frozen shoulder often can't rotate their arm out. And then I'll go around the rest of the shoulder and then essentially sort of release all the way around so the patient's got their full range of movement back. And we can do that just a simple day case procedure, and the patient only needs a sling for a couple of days. But ultimately, whatever you do to treat a frozen shoulder, you need the patients engaged. You need to be in their head. They need to be clear that they need to work hard, take their painkillers and work hard with their physiotherapists, okay? Physiotherapists are key. In terms of shoulder arthritis, fortunately, shoulder arthritis itself is much less common than it is in the hip or the knee, and the causes are more or less the same. The only difference being what we call cuff tear arthritis, where someone develops arthritis in the shoulder after having torn all the tendons. Now, arthritis obviously causes pain, it causes stiffness, and it also causes a lot of clicking and creaking and crunching in the shoulder. Sometimes patients say their shoulder talks to them, it's that noisy. Night pain, patients often suffer the night pain, and that usually is the sort of the last straw. And it's at this point they want to come and see me to find out what can be done about it. A lot of patients see their GPs. There's a big penchant for having ultrasound scans these days, but an ultrasound scan won't tell you if your shoulder's arthritic. Simple x-rays are all you need. And now, what can we do to treat it? Well, we can use a variety of different painkillers. Obviously, patients have a chat with their GPs, find, painkillers that can try and suit them. A lot of patients, if they've got very early arthritis, try things like glucosamine, which you can buy over the counter in the chemist. Sometimes we'll do injections to try and buy some time. Patients often get some temporary relief. And we can either use steroid or we can use other substances known as hyaluronic acid, which is effectively like a lubricant. We're trying to replace the normal fluid in the joint to try and keep it going. But if a patient's got very severe arthritis and they're essentially gone past the point of simple painkillers, simple injections, we then enter the world of shoulder replacements. And there's lots of different shoulder replacements, and the technology's really advanced over the last couple of decades. And you can see from these pictures that there's different types. There's ones where we essentially just sort of resurface or replace part of the head and have a very short stem. We can then have a stem that goes further down the bone. You can also see on the top picture on the right, you'll see, well, that looks like the ball is on one side and the cup is where the stem is. And that's what we call a reverse geometry arthroplasty. And we use those type of joint replacements in people who've lost the tendons in the shoulder, as well as having arthritis. And technology really is coming on at a pace. And these days now, we use a lot of computer software as well, so we can sort of pre-template what type of shoulder replacement we want to put in. So even before I enter the shoulder, I'll have an idea of what type of shoulder replacement, what size implants, where I want to put them, so I can try and optimize patient's outcome. And this is really the next frontier in shoulder surgery. But Do shoulder replacements really work, and what are the issues in relation to Parkinson's disease? Well, if we look at the results of people who've had a reverse shoulder replacement, so we've used this implant in patients who've had arthritis, but they've also torn the tendons. So we put the implants around the other way, so that helps the deltoid muscle, which runs over the top of the shoulder. It helps that muscle work better. Okay, it increases the moment arm. For those of you who can still remember some physics. Pain relief is similar to non-Parkinson's disease patients, so it's really good for getting rid of pain. However, the range of motion is often less predictable. So when we see a patient, we've got to be careful and counsel a patient who's got Parkinson's and wants to know, how good is my range of movement going to be? It's less predictable. Some people do really well, some people can do not so well. But one thing that is quite clear is that the complication rate is higher. And in particular, we look at instability. Now, instability means where the implants actually become separated. And a lot of that is because of the neurological sort of tension in the soft tissues and the muscles and the tendons, which will then cause the actual joint to actually dislocate. And that's a big problem in patients who've got Parkinson's disease and have a total shoulder replacement. And anyone who's having a shoulder replacement should be warned of this by their surgeon prior to the surgery. Now, TSA stands for total shoulder arthroplasty, so total shoulder replacement. And this group, Krzyzak, Sperling, Shuck and Cofield, this is the group from the Mayo Clinic. And for those of you who don't know, the Mayo Clinic is one of the most major, renowned institutions for healthcare in the world. And Bob Cofield is a legend in shoulder surgery, and they looked at their patients who had Parkinson's disease. It was clear that there was significant improvement in pain. Very clear that their range of movement, particularly in rotation or abduction, which is when you move out to the side, was better. However, you've got to be, concerned about the complication rate, because 8 of the 36 patients had needed to have another operation to revise the shoulder replacement, with 3 in the first year due to instability. So that's a little whistle-stop tour of shoulder arthritis, joint replacements, and what the issues are relative to Parkinson's. If we remember from the first slide about the different causes of shoulder pain, we'll now look at the tendons rather than frozen shoulder and arthritis. And with the tendons, you can see on this picture that we're looking here at a right shoulder from the front. You've got the shoulder tip at the top. The blue sort of balloon is what we call the bursa, which is tissue that runs over the top of the rotator cuff tendons. And then you've got that supraspinatus lesion, which is the main sort of rotator cuff tendon at the top of the ball of the shoulder. And that tendon can sort of rub, it can catch, and patients often, seek sort of medical opinions regarding impingement of those rotator cuff tendons. Unfortunately, the vast majority of people settle with physiotherapy and an injection of steroid or 2. A few patients, if they fail a good course of physiotherapy, so I'm not talking about a course of physiotherapy where you've gone to see your physiotherapist, you've had a chat for 20 minutes, you've gone home with some TheraBands, you've done exercises maybe a couple of days, and then you said, oh, it's not working. No, give it time with the physiotherapist, give it time for some steroid injections to work. But if all that fails, we can do an arthroscopic decompression whereby we clear out the inflammation and make a bit of space for the tendons to work in. And when we do that, this is just a schematic diagram of how your shoulder tip can be a bit hooked. And it may or may not be relative to impingement of the tendons. But if we do a procedure, what we do is just smooth the shoulder tip off. And this is how it works. This is a right shoulder, and we're going to do 3 tiny incisions, one at the front, one at the back, and one at the side. And then we'll put the camera in, and then use our instruments coming from the side to shave the bone. And this is what it looks like in real life. We've got the camera between the tendons, which are at the bottom, and they're moving because I'm rotating the patient's arm. We can see there's lots of redness, lots of inflammation, and you can see how frayed the tendon is, and also the tissue at the top, how frayed that is from the tendons rubbing together, okay? And then I'll put my trusty old radio frequency probe in, and we'll start to clear that tissue away. And then once we sort of cleared it away, that sort of switches off. We're sort of essentially sort of buzzing away a lot of the pain fiber, the pain receptors in the shoulder to try and improve the pain. So all that red inflamed tissue, we're essentially hoovering it all out. And again, this is something which is done as a day case procedure. But I would only do this after conservative measures have failed. Unfortunately, I don't have to do this procedure very often at all, because most patients will get better with physiotherapy and or injections. And then you'll see, in this case, there is a bit of a spur of bone at the front. And we'll get to that in just a second. If you just bear with me. And then we clear that out. And then you can start to see the sort of little pinky bits of bone, which we then shave away to make some space. And then ultimately we have a space like so. So you can see the bone at the top and the tendon at the bottom. Patients can develop rotator cuff tears, so tears of the tendons. Now, the first thing to sort of reassure you about is that rotator cuff tears are actually common over the age of 60. By the time we're 70, over half of us will have a tear of one of the tendons in our shoulder anyway, and we won't even know about it, okay? Our tendons generally sort of, get a little bit worse for wear as we gradually get older. Now, one of the mysteries of rotator cuff tears is that the pain doesn't necessarily correlate with the size of the tear. There are some people who have a really small tear and they're in agony. There are some people who have a huge tear and they barely know about it because their shoulder is essentially compensated for that tear. What we don't understand is why some people compensate and some people don't. But if a patient's failed to recover with physiotherapy, they've got ongoing pain and weakness, or certainly pain that's waking them up at night time, and they're willing to go through a long period of rehabilitation afterwards, then a repair of the tendons is possible. And again, an example using on a right shoulder, we put these sort of what we call cannulae in, these sort of plastic portals, and we use these sort of plastic anchors. So the ones on the top left are ones which screw into the bone, and then the one on the top right is essentially a very rather expensive medical plastic raw plug for all intents and purposes. And these are what we use to tie the stitches. Now the stitches are pretty sort of advanced, very high tensile stitches, okay? They're very, very difficult to break. And what we do here is that tissue which these stitches run through is the rotator cuff tendon, okay? Which I've spent the last sort of 20 minutes sort of fiddling through keyhole. And then you can see if I was to pull those stitches across, that big sheet of tendon then comes across the view back into place where it should be. And that if I was to then tie knots in those stitches, that would tie the rotator cuff tear back in place. And on this slide, at the top, that's what it looks like before if we were viewing from the side of the joint, looking upwards to the tear. So you can see with the hook, that tendon's all torn off the bone. So you see the yellow area, that's where the tendon should have been attached to, but it had pulled off. That's the tear. And then we can see in the larger picture what it looks like after we've stitched it all back down in place. You can see a lovely bit of rotator cuff tendon stuck right back down where it should be. And that's just what a rotator cuff repair looks like in real life. So in summary, we've sort of done a sort of a whistle stop half an hour talk through the causes of shoulder pain, and in particular frozen shoulder, shoulder arthritis, impingement of the tendon, and rotator cuff tears. And I think really in terms of sort of Parkinson's, the big focus sort of for me as a shoulder surgeon is really on the realm of frozen shoulder and also arthritis in particular when it comes to actually performing joint replacements. And I think the take-home message really sort of from my point of view is that shoulder pain is, as you know, is very common in patients with Parkinson's disease. It can also be how they actually present with their disease in the first place. That's something that I need to be aware of and to keep an eye out for. And then in terms of shoulder arthritis, Fortunately, shoulder arthritis is quite rare. It's not as common as in the hip or knee. But if patients are debilitated by their pain and they need a shoulder replacement, well, there are lots of different types of shoulder replacements we can do. But one thing we always need to consider is that the complication rate, i.e. the risks of the surgery, are higher than what we would normally expect. And that's something to have a good chat with the patients about before they sort of agree and proceed with the surgery. If you've got any queries, problems in the future, Amanda, sort of, you know, we seem to have I have two women who run my life. Obviously, I've got my wife, and then sort of in work, Amanda tells me what to do. And then if you're sort of interested in shoulder pain, I have my website, which is tcshoulderelbowclinic.com. This has got lots of information about the various sort of shoulder problems, the causes of shoulder pain, and also the treatments involved. And it's not written for doctors, it's written for patients in nice patient-friendly language. And it can be useful that if you see one of your doctors and they mention frozen shoulder, cuff tears, or some of the treatment, you can't remember half of what they've said in the consultation, you can at least go to the website and just help try and understand and refresh some of your memory. And if anyone does have an operation, their physiotherapists can go onto the rehabilitation section, where I've got the rehab protocols for all my operations, and that's one of the most popular areas of the website.
Tony, can I come in just before I leave?
Yeah.
I found your talk absolutely fascinating, primarily because I've had a shoulder problem for about 30 years. In my younger days, I had to take part in free-fall parachuting, and I landed very heavily, and I dislocated my shoulder. A year later, I went back to it again, and damn, I did it again. And since that time, over the period of time, every now and again, I do something like that, and it releases it. In recent years, touching wood, I've been okay. I take chondroitin and glucosamine, as you just said. Unfortunately, I seem to be okay. I'm so disappointed I've got to leave you now, but I found your talk absolutely fascinating from a personal point of view, and I'm sure everybody did as well. And can I personally thank you for that? And it's if I get any problems, I know how, again with the shoulder, I know how I'm coming back to talk to. So I do thank you very much indeed, Tony, for your time and talk to me about it. Just to complete the story, I also got exactly what you said with my left shoulder on occasion. I went to a surgeon in Great Missenden, I can't remember his name sadly, and I had keyhole surgery on that left shoulder to remove or do something. And again, touching wood, that's been perfectly okay over the years. So yes, it's been brilliant. And Tony, I do thank you so much indeed for your time.
Pleasure. Thank you very much, Keith. Thank you very much indeed. Much appreciated. Okay. Thank you.
I have to leave you, everybody, now, so I look forward to talking again soon. Sam, I'll be in touch.
Okay. We can only see Tony in his screen at the moment.
Okay, yeah, so I'll come off the screen share. So, yeah, thanks very much. I'll try and come off the screen share now.
Brilliant, wonderful. I think that was amazing. I'm absolutely gobsmacked about that looks like the inside of a shoulder, because my shoulder's been such an issue for me for so long. But anyway, so are there any questions from people other than me?
Yes, please, Ruth. It's Graham.
Right, go on, Graham.
Well, Tony, that was a fantastic talk. It really was. June, my wife June, has had 2 shoulder replacements. Yeah. She's had Parkinson's for 24 years now. And it wasn't due to the Parkinson's, it was due to osteoarthritis.
Yes.
Or osteoporosis, actually.
Yeah.
A colleague of yours, Andrew Irwin, did the jobs.
Yeah.
And he did them both at different times. I don't know if part of it was due to the fact that when we were in Bolivia, in La Paz, and having Parkinson's, she fell, as she often does, fell on her shoulder, and it cracked the ball.
Right.
That, when we saw Andrew, he said, that looks as if it's healed up well.
Yeah.
But later on, both shoulders had to be done. Now, my question is, June still has to take painkillers occasionally. I think there's a little nodule there. Mm-hmm. Is there anything on the stem cell front that might help with the cuff. What Andrew did, he left the cuff, drilled little holes in it, as far as I understand, as layman's terms, obviously.
Yeah.
Tony.
Yeah.
Drill little holes in it and let that grow around the ball joint that he put in there.
Yeah.
That was, I understand, a normal sort of thing, or one of the possibilities. Is there anything these days, because this was 10 years ago, is there anything these days that stem cells might help with? And at round about the late 70s, early 80s timescale, is stem cells a possibility? Using pluripotent stem cells.
So stem cells, in terms of the world, I'll answer that sort of in two ways. One about arthritis, and one about sort of rotator cuff tendons. In terms of arthritis, there is work being done on stem cells to try and prevent the progression of arthritis. So obviously, before you have a joint replacement and you're developing arthritis, there is work going on, and particularly sort of in the hip and knee where it's more common. And we sort of extrapolate that to the shoulder. So far, there is not great evidence for stem cells stopping the progression of arthritis. There is, so there are some clinics in London, central London, where there may be, I'll choose my words carefully, clinicians who will market the idea that you can have some sort of stem cell or what we call lipogem, and that it may improve your pain. There's no hard evidence in the medical literature in terms of research papers to show that it actually stops the progression. There is a bit of evidence that it can improve a bit of the pain, but that's probably from an anti-inflammatory effect of the stem cells, okay?
But you could have an injection for the anti-inflammatory side of things with steroids,
exactly.
couldn't you?
Oh, you can, absolutely. So you could have an injection, but then if you're saying to a patient, these treatments are only done in private clinics, and say, for instance, there will be one type of injection, and it sets you back thousands of pounds, thousands. Or you can have a steroid injection, which will probably give you just as much relief for just as much time for an absolute fraction of the cost. So you just got to be careful you don't get caught out by the snake oil salesman.
Yes, thank you.
Sort of out on the street. I'll just look. I call a spade a spade, and you've just got to be careful on that. In terms of tendons, there's lots of work done on, rather than sort of stem cells, what's called platelet-rich plasma, which is where you have a blood sample taken that gets spun down in a centrifuge. And then there's a small layer which is essentially got all the goodies which we naturally have in our blood that we use to heal our tissues. And that can then be injected into a defect in the tendon. Now, it's used a lot in, say, tennis elbow, it's used a lot in sports medicine. But in the rotator cuff, there's not much evidence that that actually makes a tendon any better. And it certainly doesn't heal a tendon which is torn. If a tendon is torn off the bone, the only way that repairs is if you actually stick it back in.
As you did it. I was thinking more about the cuff, the lining of the cuff itself.
So basically, the cuff, in the world of shoulders, the cuff is what we call the family name for the tendons.
Oh, sorry. I thought the cuff was where the ball went in.
Yeah. So no. So that's the socket, which we call the glenoid.
Okay. Right.
And what you can do, if a patient has only had the ball replaced and not the socket, but the socket's got a little bit of arthritis, then what you can do is actually just sort of drill some holes. We call it microfracture. And the idea, and this is where you got the idea of the stem cells from, is that by making some little drill holes, then the blood comes out from the bone marrow in the socket with the idea of forming new cartilage. And where that originally came from is in the knee, where you'd have some patients with knee pain, where the vast majority of the surface at the end of their thigh bone would have good cartilage. So not nice carpet, nice cover, but there'd be a small defect. So imagine if you got sort of like a small defect there, but everything else is okay. You're not going to do a knee replacement on something, you know, which is predominantly okay. So people would start doing a microfracture in that area to try and stimulate a bit of new cartilage to form.
Right. And essentially that's what Andrew Owen did with
Yes.
Jim's
Yeah.
sockets.
Yeah, absolutely.
Brilliant. Yeah.
And
Can I just follow that up with, is there an age limit for when stem cells can't be taken from the person themselves?
Not to my knowledge, no.
Okay.
But stem cells at the moment, we know it's not proven at the moment. It's still experimental.
Thank you. That's
No
excellent. Thank you very much.
Who else? Oh, Janet. Janet wants to have an answer to this question.
Janet, you're on mute, so just come off. That's it.
Yeah, people with Parkinson's, when they request physiotherapy, there's quite often a bit of a difficulty between whether they go musculoskeletal or to the neurophysiotherapy. Have you anything to say on that?
I think when it comes to the shoulder, I'm sort of very fortunate that certainly in the local area, I know a lot of the physiotherapists who've got a special interest in the shoulders. And they're good enough that they should be able to tailor any rehab regime to accommodate the needs and have an understanding of the challenges that patients with Parkinson's face. I think the world of sort of neuromuscular physiotherapy is an extremely demanding and complex area. And there may be, a lot of it depends on what training the physiotherapist and what background they've had. They may not have a huge amount of experience on the shoulder and how to really rehabilitate, for example, a rotator cuff. On the flip side, you may have someone who's fantastic at shoulders, but not really have a true grasp and understanding of the challenges that patients with varying degrees of Parkinson's can have. My preference is initially to go musculoskeletal if you've got a shoulder problem. That's, normally the people who I deal with. But what I would say is that you really need to be seeing a physiotherapist face to face. And one of the challenges is this the dichotomy between NHS physiotherapy, which is under tremendous strain. There's huge waiting list times. When you finally get to see a physiotherapist, they may just sit there, go through an exercise sheet with you and say, look, here's what you need to do at home, crack on. I think the key is that you need to be seeing a physiotherapist, whether it's in the NHS or private, who has the time to actually devote to get to know you as a patient from a neuromuscular point of view, but then also have the time to then tailor a rehab regime that suits your capabilities and your ability to help get your shoulder in as good a condition as possible, if that makes sense.
Yes, that's not easy to find.
Yeah.
And also the discrepancy between your ability when you're on medication and off medication.
Yeah.
Functionality can be completely different.
Yeah, and that's where a lot of the frustrations can be, that depending on what physiotherapy service you've been referred into, is that you may end up seeing, if you do see a physiotherapist on the NHS, if you're lucky enough to see a physio, and then lucky enough to get another face-to-face appointment, it may well be with someone completely different, and I think it's important when you've got huge challenges and you've got a patient who not only can have variable functional level because of their shoulder, but also have a completely different functional level depending on how they are with their Parkinson's. You need a physiotherapist who knows you and knows your story, knows your fluctuations in performance level, etc. And I think that's one of the more important things, is to have a relationship where you have a continuity of care with the same therapist.
Would you allow me one other quick comment? Does Parkinson's and the dyskinesia and the muscle tension make arthritis worse or make it develop?
To my knowledge, there's no evidence that it actually causes the arthritis. Fortunately, in the shoulder, the forces across it are not as great as obviously joints like the hip and knee. So we don't see shoulder arthritis anywhere near as common in the hip or knee, which is very fortunate. Very fortunate.
Very much, and thank you for your talk.
No, pleasure, Janice.
Anyone else?
Ruth,
Yes.
can I just pass a message to Janet, please?
Yes.
Janet,
Hello.
we know a very good neuro physiotherapist that's had a lot of training in Parkinson's. June has been to her several times and she is excellent. Thoroughly recommended. She's private, but thoroughly recommended. I'll give you a ring afterwards if you like.
Thank you very much. Thank you.
Okay, Janet.
And I have one, and I have one too. So carry on. And who else wants to ask a question?
Michael Sanders.
Go ahead, Michael.
Yeah, go ahead,
Oh,
Michael.
thank you very much.
Sorry.
First of all, I found that a fascinating explanation. I'm 82. I've been diagnosed with Parkinson's 2.5 years ago, and I wake up in the morning and it's almost as if both my shoulders have seized up. But then when I gradually get going, I'm all right for the rest of the day, unless I stop for a sleep or something in the afternoon, then I've got to go through it again. Is there any logical explanation for this?
It's an interesting one.
Yeah,
Interesting one.
Yeah, thank you for that, Michael. A lot of people with lots of different musculoskeletal problems will get sort of morning stiffness. You know, when you first wake up, it takes a bit to get going. I have to say, I can be like that myself sometimes.
Yeah.
But, you know, I sort of appreciate the first thing you think of is that it's Parkinson's related. I think if it sort of persists, or certainly if you're getting stiffness in the morning, which is not necessarily just the shoulders, but say in the small joints of the hands, it can often be worthwhile. If it ever gets to that point, that's when I often say to patients, you know, to pop along and see a rheumatologist to make sure that, you know, there isn't anything else going on, like some sort of more generalized inflammatory condition of the joints. Because I think it's important sort of as doctors that when we have a patient in front of us who has a very complicated condition such as Parkinson's, it's easy to just attribute everything to the Parkinson's. But we must always keep an eye out to make sure there isn't something else going on in the background.
It's only come on since I started with Parkinson's, and but anyway, very interesting talk. Thank you very much.
Very much.
Thank you, Michael. Who else would like to ask a question? Anyone else?
I've got a question, please, Ruth. Yeah, I just wondered if there's any exercises, please, Tony, that we could do to avoid things like frozen shoulder, or just to keep the shoulders supple.
There are, and I've actually, you know, I can certainly sort of send some links to some YouTube clips of what we call capsule stretching exercises. Capsule stretching exercises are, in fact, what I can do, I can even put the links on my website for people to sort of go to. The video clips were done by Joe Gibson, who is a wonderful specialist shoulder physiotherapist, one of the most famous shoulder physiotherapists in the country. And she's in, you know, my hometown of Liverpool, and I'm not biased at all. But Joe's fantastic, and she's actually sort of very influential in sort of physiotherapy education, British Shoulder Society, etc., etc. She's done some video clips clearly explaining some exercises to do, and what I'll do, I'll put those links on my website so the patients can, so any of you can go to the rehab section, and then I'll just put it under a little title, sort of capsule stretching exercises, and that will take you to the links of the YouTube videos, which just show you very simple stuff. You don't need any complicated equipment. The most you'll need is an umbrella, okay, to just use as a stick to help push your hand out to one side, okay? Right, you don't need to go buying anything on Amazon.
Marvellous. Are there any other questions from somebody? I'm sure there must be.
I've got one more, if that's all right, Ruth.
Yeah.
I wonder if if shoulders, if sleeping on the shoulder causes a problem, or so to sleep on the other shoulder would obviously help. But would you recommend any kind of pillows that might, because you get these foam pillows, etc.
Yeah.
I wonder if that would help ease pain for people.
I think, yeah, great question, Simon. I think it's a very individual problem. I see lots of patients who will say, well, I can't sleep on my shoulder because it's painful. And often patients can get a bit of arthritis, which we all get at the end of our collarbone. When we're over 40, we all get a bit of wear and tear, but some people start to get a lot of pain and tenderness just up at the top of the shoulder. So if you lean on the shoulder and sleep on it, that can sort of aggravate matters. There are some people, however, who will say have pain from the tendons or arthritis, who then say, well, they roll onto the other side and they think it's going to be fine, but then when their arm flops over, they find that that again is a position which aggravates. So it's very individual. And certainly for patients with arthritis, what you often find is there's, depending on how bad the arthritis is or what position, they can sometimes find a position which is more comfortable. And it may actually be not related to the pillows behind their necks. It may be more about just sticking a pillow behind their back or under their arm, having their arm in a certain position which they find is the most comfortable position. So I think it's very much a trial and error for patients, in that I wouldn't go spending lots of money on specific pillows. I would just do a trial and error of what position works best, and then tailor whatever pillows you need to maintain that position if that's the most comfortable.
Thanks very much, and really enjoyed your talk. Thank you.
Anyone else want to ask a question? If not, can I just thank you, Tony, because that was really, really good. And you have so far a record number of people tuned into you.
Have we? Oh, we're trending now, are we?
Absolutely, yes. I think you're now super talker. And I want to thank you very much because